Welcome to the 51st annual meeting of the STS and game day for percutaneous mitral valve replacement and repair techniques. I'm Vinod Thourani. I'm a cardiac surgeon from Emory University in Atlanta, Georgia, and I'm absolutely thrilled to have an esteemed group of guys next to the right and left of me. And first we're going to start off with indications, first we're going to start off with introductions for the esteemed panel, and then we're going to get into some very exciting technology coming forward to you. Dr. Mack?
So I'm Mike Mack, and I'm at the Baylor Scott & White healthcare system in Dallas.
I'm Gorav Ailawadi from the University of Virginia in Charlottesville.
I'm Roselli, an adult cardiac surgeon at the Cleveland Clinic.
And I'm Wilson Szeto from Philadelphia at the University of Pennsylvania.
Great. So Gorav, let's first start off with you. Just tell us a little bit about the MitraClip. It's the only one device that's currently approved in the United States for percutaneous mitral valve therapies. You're one of the largest users as a surgeon and doing them primarily as a surgeon. Just tell us a little bit of how that's affected your practice and where that fits in.
Okay. Well, MitraClip is unique because it's one of the few devices that we have a fair amount of data on. There's actually, as you know, the randomized trial of putting the clip on versus surgery, and that has ultimately led to approval for the MitraClip in patients with degenerative MR or primary mitral valve disease who are considered at prohibitive risk for surgery. So the term prohibitive risk obviously means different things to different people. We use various things like risk calculators with the STS, the eyeball test, frailty assessments, and other things that aren't included in the database calculators like porcelain aorta, a lot of severe mitral annular calcifications, and those things together through a heart team approach between our cardiologists, surgeons, heart failure team will help try to assess the risk of any patient that's higher risk or inoperable being referred for mitral valve disease. In essence, if they have degenerative mitral regurgitation and we do feel they're not candidates for surgery or not optimal candidates for surgery, we really evaluate them for MitraClip as a primary option. If they do have functional mitral regurgitation...
So going back, the primary indication currently in the U.S. is for degenerative mitral valve repair.
In patients who have prohibitive risk for surgery.
Right. Okay.
Correct.
Let's make sure everybody understands that it's not approved for functional at this time.
Not at this time.
Right.
Unfortunately, many patients we see, we don't really know what their mechanism of mitral regurgitation is until we really start to evaluate it at our own institution, maybe get transesophageal echo at that time to understand the mechanism. If it turns out they have functional MR, it is not currently approved for it. However, there's an exciting trial, the COAP trial, which Mike Mack is the PI, and we're really pushing those patients into that trial.
So your workup, I want to mention that you mentioned a TE, and I think that's critically important, but it's a special TE. It's not the same TE that we normally get on most of our patients. There needs to be a good 3D component to it. You need to have 3D capability for that. So any comments on that? What are your thoughts?
Yeah, I don't think you necessarily need to have 3D. I think it's helpful. A couple things that are absolutely essential. You have to understand where the primary jet is, how tall the gap is. If it's a really large gap, then it's going to be hard to capture with a MitraClip. How many jets? Sometimes there's multiple flail segments. One of the other important things that we probably get more from a surface echo is actually the mitral valve area. Because if they have a small mitral valve area to begin with, particularly in somebody with mitral annular calcification, their valve area is 4 or less, you're going to be pushing the envelope and really trying to put clips on. You may cause damage by causing mitral stenosis.
And I think it's important to look at that retracted P3 leaflet also, because those don't do nearly as well, in my opinion. So, Dr. Mack, you've been very instrumental in a major randomized trial that's coming up. Can you talk to us a little bit about the COAP trial?
Sure. As Gorav mentioned, the MitraClip is approved in the United States only for high-risk primary mitral regurgitation. For secondary mitral regurgitation, there's a pivotal trial going on. I'm honored to be one of the principal investigators of the trial, along with Greg Stone, an interventional cardiologist from New York, and Joanne Lindenfeld and Bill Abraham, who are 2 heart failure specialists. This is a heart failure trial. Despite all the years that we've been correcting functional or secondary mitral regurgitation surgically, it's never been shown that that it improves prognosis or changes survival. Despite the fact that we can acutely correct the mitral regurgitation. The importance of this trial, which is randomizing patients between guideline-directed medical therapy with resynchronization as appropriate versus guideline-directed medical therapy, and the MitraClip will tell us for the first time whether correcting secondary mitral regurgitation, which is a disease of the ventricle and not of the valve, whether that does anything to change the course of the disease. It's 430 patients. 70 sites are enrolling in the United States. There have been about 170 patients enrolled in it. And it's a very difficult trial to enroll. Anytime you randomize between a procedure and medical therapy, it's very different. Dr. Ailawadi's site at the University of Virginia, along with Scott Lim, are the highest enrollers in the United States. So they've been doing a great job on it.
Can I ask a question about
Yeah,
the
of
trial?
course.
Mike, we know that from the surgical experience, we don't change survival in those patients, but we do improve their quality of life. Is there some other additional endpoints in the study looking at that?
Yes, so the primary endpoint of the study is a composite that includes survival and repeat hospitalization. So it is a heart failure study and using all the primary endpoints of any other heart failure study, including 6-minute walk test, functional outcomes, quality of life, et cetera.
So how big is MitraClip in your practices? And so for our institution, I would say it's less than 10% of our mitral valve practice. Give me a sense of where people should expect, if they start a program, where has it grown and where is it currently?
Well, I guess we could start. It is also a smaller percentage of our total mitral valve practice. I will say that we do get a lot of referrals for MitraClip, and many of them, for whatever reason, either they're really cohort C, we can't offer anything, or it turns out they're a surgical candidate, or their anatomy really isn't feasible for MitraClip, and then we're still considering surgery. And so,
Or they fall out of severe MR with good guideline management,
that's
correct?
true.
Right.
Yeah.
Or their MR isn't significant
Right.
enough for whatever reason. And so I'd probably say it's 10 or 15% of our practice are we considering something other than surgery?
Mike, do you agree with that?
Yeah, I think you have to think of the MitraClip or any transcatheter mitral valve therapy as a part of your portfolio for the treatment of mitral valve disease. Everything from heart failure specialists that know guideline-directed medical therapy to electrophysiologists for resynchronization therapy to MitraClip to minimally invasive surgical
Or robotic
procedures
also.
or robotic
That's right.
also. So it's whole part of a portfolio for disease management of the mitral valve.
Great. And Wilson and Eric, your thoughts on that?
Yeah, I agree. It's a small portion of our practice now, but it is.
Should
but the experience
surgeons
is
even
growing.
do it then, right? I mean, so if it's a small practice, should surgeons get involved? I mean,
Well,
this is a question that people ask me all the time.
I think that's a great question, and I honestly believe surgeons should be involved because it does, to borrow a page out of the playbook of TAVR.
Yeah, this is game day, so you can use those words.
That's right. This is part of the heart team,
Yep.
and similar to what we did in aortic disease, similar to what you have in Cleveland Clinic. We translate that to the valvular disease, aortic valvular disease, and now I think it makes sense to transition that into the mitral arena. So I think it does.
Well, I
make
think
sense.
that's a great analogy. So what we saw with TAVR is that we opened up a real mechanical therapy for patients who didn't have other options before.
right.
And so I think as this technology evolves, it may not just be eClip, but as the other mitral valve technologies evolve, we're going to find that patients who maybe aren't anatomically feasible to something like eClip have another percutaneous option when they're not a good surgical candidate.
Absolutely perfect. So that's a great segue into something I want to ask Dr. Mack about, early feasibility trials. Since we mentioned new transcatheter technologies, the big difference, in my opinion, from TAVR to transcatheter mitral is that we're going to see this stuff before it's done thousands of times somewhere else and not in the U.S. Mike, can you bring us up to speed on early feasibility trials of the FDA?
Sure. So I think, first of all, to take a step backward for a minute, I think everybody needs to think this as the early days of TAVR all over again. So this is 2004 Redux. The difference this time is that we are going to be able to access the newer technology earlier in the United States than we were with TAVR. The FDA has opened up an early feasibility program which will allow for the first time first-in-man and early feasibility trials to do in the United States. Transcatheter mitral valve replacement is coming. There are other new repair technologies that are coming.
So should we see replacement this year, Mike? You say it's coming.
Yeah, well, there are, the FDA has approved 3 companies to do early feasibility trials of 15 patients each in the United States. And so, yes, I think we will see 3 trials a total of 45 patients, at least in the United States this year.
Spectacular. Good, and I think there are a lot of people to thank for that. John Lassinger, who we've gotten to know well, you know very well, is a big part of the Device Center for FDA, and so we owe him a lot of gratitude to helping us push this agenda through. So, Mike, since you know a lot about this, tell us, as you said, there are 3 mitral replacement techniques coming into the U.S. How many patients have been done worldwide before they're coming to us?
So there have been under 20 patients done worldwide with the 3 valves that will come to the United States. So this truly is early stage access to new technology in the United States. It really is a different day than it has been before, and it's actually a very exciting one, and I think that perhaps we can get into it, but these will all be done by a transapical approach.
As far as I know, that's correct also. I'm looking forward to it. So Wilson, comment a little bit about mitral valve replacement. Is it going to, what kind of patients are we looking at? Are we looking at all type of patients? Just tell us a little bit about that.
I think that's a great question, and at least certainly for the early studies, I think these obviously are going to be very high-risk patients.
Should they be compassionate use, or should they be high risk?
I think we have to be careful about that. I think what we've seen in Europe, when you go down the compassionate route, almost you almost pass the point of futility. You got to be careful. I think we should be smarter. I think compassionate would perhaps suggest patients that may be beyond the help of therapy. I think high risk, prohibitive risk may be a better term. And I think that's what the 3 studies in the United States are going to be geared towards, not compassionate use, but patients who are at high or prohibitive risk.
So are these patients, in your mind, are they going to be degenerative? Are they going to be primary? Or are they going to be secondary? What type of mitral regurgitation therapies are we talking about?
Well, I think certainly in the long term, I think you're going to have to think of those 2 disease processes as 2 different animals.
Right.
I think we know from all the data in the surgical literature that prognosis and therapy is different for primary versus secondary. At least what I see in the near future for transcatheter mitral replacement will be focused on a high-risk secondary functional MR. And a lot of this has been based on of the recent CTSN Cardiothoracic Surgical Network publication on secondary mitral regurgitation, severe replacement versus repair. I think that data really lends itself nicely to support taking this first step towards transcatheter mitral valve replacement.
And so in that report that was published by the NIH CTS Network, Michael Acker was the first author for that in the New England Journal of Medicine. And that trial did show the replacement in that subgroup at 1 year was more beneficial than repair from mainly.
Showed that it was equivalent.
Equivalent, yeah.
In
but
terms
no,
of the
no,
reduction.
as far as I was going to say about mitral regurgitation, recurrence of mitral regurgitation.
So,
correct, sorry.
no difference in mortality.
Right.
Much better in terms of recurrent mitral regurgitation in the replacement group.
So has that changed your practice at all, Wilson?
Very good question. It has a little bit. Certainly the discussion with the patient, when during consultation. I would have to say I'm doing more replacement than in the past, but by no means it has to skew me towards replacement for everybody.
Right.
For example,
Eric, do you agree?
I think we're learning a lot about these functional MR patients. So no surprise, I think, to see that mitral valve replacement did just as well, if not, maybe not better from the MR perspective in those patients. And what we learned from that co-op study is going to be really instructive. What was surprising to me was that it was a little more difficult to find functional MR patients to put in these trials because we're getting better with our treatment of ischemic disease. So, the moving target of the disease is really interesting. It just highlights the importance of us building these heart teams around understanding all this. And the technology really kind of forces us to do that as a team. It's pretty exciting for me.
So where do you see transcatheter mitral replacement? As Mike alluded to, there are 3 of them. There's the Edwards Fortis valve, there's a Neovasc Tierra valve, and there's the Tendon valve. Those are the 3 that have FDA approval to potentially look into early feasibility trials here. Where do you see that fitting into your patient population? Are you going to think about a 75-year-old redo who's got an EF of 30%? I mean, where patient population?
So I think that the functional MR is probably ultimately going to be treated percutaneously, either with a clip or a mitral valve replacement sometime in the next very few years. The other population of patients who are high risk, who I think we really need to learn more about, are the patients with degenerative mitral disease, mitral annular calcification, valve dysfunction. And they may end up being a really good patient for mitral valve replacement options. Right. But we don't understand those patients very well. We know from surgical, if we can get them through the operation, that we do probably improve survival by getting the mitral valve taken care of. It's just hard to do right now surgically. Yeah. The transcatheter technology may expand treatment for those patients.
So people talk about systolic anterior motion, SAM, and aspects with mitral valve replacement. Gorav, talk to us about complications that you've heard of for transcatheter mitral valve replacement. Are you worried about that from the preliminary data?
The initial studies that I know about from Europe seem to be less of an issue, at least than I would have thought. Certainly has happened, at least my understanding, with a few of these cases. But just based on the anatomy, I would have worried that it might happen more often. I think the other part of it is some of these hearts are pretty dilated, particularly if they have functional MR. And so I think in those particular cases, it's probably less likely. And I know in the development of these technologies, the companies are trying to think about it and try to use some technology to try to keep that anterior leaflet from getting into the outflow track. So it's a consideration, and it's been one of the limitations for why TMVR is lagging behind, along with the fixation in a non-calcified location. But I think that those things probably will ultimately be achievable.
Mike, what are you worried about the complications? Are there things that you've seen that makes you concerned about the new replacement techniques?
No, I think Gorav has outlined it very well. I mean, you're dealing with a different ventricle than we were with aortic stenosis, so left ventricular outflow tract obstruction should be less of an issue. Plus, companies have been working on this 6, 8, 10 years, and the design features of the device all take into account some aspect of incorporating the leaflets or seating on the leaflets or doing something to keep them out of the left ventricular outflow tract, as well as sealing an annulus that doesn't have calcium in it unless you've got Mack with it. So I think there's a lot of design features, and it just shows the ingenuity of engineers of trying to figure out this problem of all the diverse concepts we have for both anchoring, sealing, as well as incorporating the anterior leaflet.
And they all have different technologies of doing that. One has a tether to the apex of the heart, other one is attaching the leaflets, and the other one just stays there. So it'll be interesting. In the last 5 or 6 minutes that we have, Gorav, can you just tell us a little bit about the 2 or 3 new technologies that are coming in for transcatheter mitral valve repair, in addition to the MitraClip that we already discussed?
So up to this point, we've only had the MitraClip, which addresses or tackles trying to fix the leaflets directly. There are many new technologies that are coming down the pike that try to create an annuloplasty, similar to what we do with surgery. We know from the surgical literature, if you correct the leaflet alone and don't fix the annulus or address the annulus, those patients down the road will get recurrent significant MR. And so the thought is, are there ways to do it? Or when you're thinking about patients who have functional MR, a lot of times we do a simple annuloplasty, a downsized annuloplasty. So there are several companies that are focusing on annuloplasty. One in particular that is coming to the U.S. soon is Valtech, the Cardioband device, which is a percutaneous through the femoral vein, a transeptal approach, very similar to MitraClip in terms of the approach, and creating a ring, a posterior ring that can be cinched down under echo guidance to directly assess MR. And that's one of the things we didn't touch upon, why these technologies are so exciting. Compared to surgery, we stop the heart, we fix the valve, we hope it's okay and restart the heart, versus these new technologies, it's real time. You can assess how is the mitral regurgitation look as you're completing and performing the repair, and that's a nice benefit. The other technology is NeoCord, which is essentially designed for degenerative MR. It's a transapical approach where the leaflet is grasped from the apex of the heart, the flail segment or prolapsing segment, and pulled down to the apex, again under echo guidance, to try to create a good coaptation height.
Yeah, I think that's right. And with the complement of the 3 replacement valves and the 2 repairs, I think we're looking at 5 companies that'll be in the U.S., most likely with early feasibility trials for the replacement ones, and probably there's been a lot of data already for the repair techniques in Europe, and they'll probably most likely go to pivotal or other type of trials in the U.S., and that's forthcoming. I think it's very exciting.
So Gorav, if you look down the line, can you see combining some transcatheter techniques like we do surgery? So combining a MitraClip with a posterior band, or an artificial cord with a posterior band, and now real-time transcatheter reproduce the multiple different things that we're doing in surgery. Is that?
Yeah. I think that's very likely coming down the pike, and likely necessary to have the same type of longevity with the success of avoiding MR, recurrent MR, that we see with surgery, which has been outstanding and traditionally been outstanding. However, we can't offer that to all the patients. Some of them are just too high risk. So likely we'll have to combine therapies. One consideration is, how do those therapies, if you try to do a repair and it doesn't work, does that still allow you to do a transcatheter mitral replacement? And that's something we'll have to see and evaluate with these technologies.
I think it's an important point. You mentioned the real-time assessment, but another advantage of an endovascular therapy, we learned from aortic surgery, is that you can stage it out. So you can use one technology, come back later and add another one to it.
With low morbidity mortality.
Low morbidity mortality, a little different than surgery.
Certain patients. And the one point I want to make is, this whole heart team concept, we're going to be even more reliant on imaging specialists.
Right.
This is very echo heavy, correct?
Right.
So echocardiography is going to play even more of a role in this new technologies before.
So how are surgeons, on our last one or two questions, how are surgeons, Wilson, going to get involved? And Eric, how can they get involved in this technology? What can they do to not get behind the times? Wilson and then Eric.
I think you have to engage your establishment, talk to your cardiologist, be open and embrace new technology. And I think you start with a good foundation of respect, and you pursue this together in a very strong relationship with your cardiologist, your echocardiographers,
and your heart failure specialist.
And your heart failure specialist. We brought that up, absolutely.
Eric,
First step is right now watching this roundtable discussion.
That's right.
Get excited about it and build your heart team, and make sure that you're an integral part of it. And the surgeon's role is important from the beginning of when you meet patients through all of their care. And so be a part of it.
Your practice 5 years from now, transcatheter mitral valves, what percentage? We said 10 to 15 now. 5 years. Wilson, we're going to do a quick round table, and then Dr. Mack gets the final word.
How many years away?
5 years.
I'd say maybe 15–20% still.
15–20%. Eric.
I'll say 25%, but our volume will grow by 25%.
Okay.
I think I would.
You're complex. You're like, it's the normal
Do the
Cleveland
math.
P. You're very
Do the math.
complex.
Yeah.
The Blackstonian
That's
statistics. I would probably concur about 25%, but I've already seen our volume grow by about 30 to 40%.
So Dr. Mack, percentage, and then after that, what excites you? And then we'll wrap up with that.
So I'm going to go on the more conservative side of probably the 10 to 15% for two reasons. One is it's going to take pivotal trials quite a while to enroll and get approval in the United States. And secondly, as Eric alluded, the market's going to grow. So the surgical volume is going to grow for the foreseeable future. What excites me most is kind of what you guys are doing in terms of training heart teams on transcatheter mitral valve techniques. With you and Vinod and Rob Smith training teams on MitraClip. You've trained, what, 30 teams now? And surgeons are part of that team of learning transcatheter mitral valve therapies. I mean, so what you guys are doing is what excites me most.
Very well, thank you so much. On that note, I want to thank our faculty. It's been absolutely great just chatting about this, and we're signing out from game day at STS 51st annual meeting. Thank you so much for joining us.